All well there?
Yeah. Jacob, we can start.
Okay, right. So good morning. I will be talking about abdominal compartment syndrome. Sincere thanks to the Higgs group, Dr. Srinivas and Dr. Ganesham sir for this opportunity. I would like to also place on record my gratitude towards my teachers who introduced me to this arena of critical care. Now, today we will be talking about the definition of abdominal compartment syndrome, what is the incidence, the pathophysiology or how it affects the various systems, how to diagnose it, and what is the management of abdominal compartment syndrome. The interest in abdominal compartment syndrome has been there for almost 200 years, but it was probably reignited by this man called Krohn et al., who's a surgeon. And he noticed that in his postoperative patients, when you have an intra-abdominal pressure more than 25, if you do a decompressive laparotomy, you improve. But otherwise, if you don't, you tend to develop acute kidney injury and death. So he published a series of 11 patients, and he suggested that in postoperative patients, if you have a raised IAP, more than 25 millimeter of mercury, with renal dysfunction despite adequate cardiac output and adequate resuscitation, then you should think of decompression of the abdomen. So that is exactly what is called abdominal compartment syndrome, where you have a raised intra-abdominal pressure of 20 millimeter of mercury, or even more than that, with or without an abdominal perfusion pressure less than 50 millimeter of mercury. This has to be recorded, preferably 3 readings or a period of 1 to 6 hours. And you always have an associated organ dysfunction, either single organ or a multiple organ dysfunction, which were not there previously. Now, ACS is abdominal compartment syndrome is a all or none phenomenon. There's no grading for that, as compared to it is the end of the spectrum where you start from raised intra-abdominal hypertension, intra-abdominal pressure, or even you start from intra-abdominal hypertension and you have organ dysfunction, you call it abdominal compartment syndrome. It is not graded as compared to intra-abdominal hypertension, where intra-abdominal hypertension is defined as a raised IAP more than 12 millimeter of mercury. Again, you should have 3 readings within 4 to 6 hours apart, and you may have an abdominal perfusion pressure less than 60. And it is graded into 1, 2, 3, and 4, but ACS is not graded like that. Now, if you look at the risk factors that have been demonstrated for abdominal compartment syndrome, this is the IROI study that was published in Australia in 2018, and they found that on the day of admission to the ICU, almost 32% of patients have raised intra-abdominal hypertension, and almost 19% of patients have abdominal compartment syndrome. Now, this incidence of intra-abdominal hypertension goes on increasing as your hospital stay or ICU stay increases. And by day 10 or day 12, you almost reach 50% of your patients do have raised intra-abdominal hypertension. And it is significantly associated with an increase in mortality. You can see that the mortality goes up as your grade goes up. So probably grade 3 and grade 4 has a higher mortality than grade 1 and grade 2. And obesity, the illness of the severity, abdomen distension, gastroparesis, and a high PEEP are factors that are associated with a raised intra-abdominal hypertension. So how do you classify abdominal compartment syndrome? Abdominal compartment syndrome can be classified into 3. There is primary, because where the pathology is primarily inside the abdomen. It can be because of a bleed, because of a ruptured abdominal aortic aneurysm, trauma, peritonitis, pancreatitis, ascites, etc. Or you can have secondary, where the cause of intra-abdominal hypertension is increased because of the increased fluid resuscitation, increased capillary leak, or etc. That is usually seen in sepsis, burns, etc. And you can have, whether it is primary or secondary, if you have it coming on repeatedly, it is called recurrent or tertiary abdominal compartment syndrome. The risk factors, as I told you, we all know that these are specifically associated with an increased risk factor. But for the exam point of view, we can classify it as risk factors that are associated with reduced abdominal wall compliance. Example, obesity, postoperative patients, prone patients, you have a muscle hematoma, you have burns with a scar, you have a tight binding across the abdomen, you have high PEEP, or when the patient is fighting the ventilator. Or you can have an increased intraluminal contents, such as contents inside the gut lumen, like gastric distension or gastroparesis or colonic pseudo-obstruction, or you can have an intra-abdominal or retroperitoneal tumor, or a patient is not tolerating your feeds, or you can have collections inside the abdominal cavity, like whether it's fluid or blood, or it's air. You can have laparoscopy can itself cause it, or peritoneal dialysis and abdominal inflammation like peritonitis and pancreatitis. You can also have other causes like capillary leak during massive fluid resuscitation, massive transfusion, trauma, sepsis, acidosis, and hypothermia. So the pathophysiology is going to be a vicious cycle. When you have an increased intra-abdominal hypertension, the blood flow to the abdominal organs get reduced. This results in reduced tissue perfusion. This reduced tissue perfusion is going to cause you tissue ischemia, lactic acidosis. Now, tissue ischemia is going to cause you the release of the inflammatory molecules, cytokines, etc., which leads to inflammation. Inflammation is going to cause more capillary leak, more tissue, tissue edema, more intra-abdominal hypertension. It also, the obstruction of the lymphatics also increases the intestinal edema, contributing to the abdominal compartment syndrome. It also causes mucosal, the capillary leak also causes increased translocation of the bacteria, which can result in multi-system organ failure in patients with abdominal compartment syndrome. So how do we diagnose it? To diagnose it, you have to measure the abdominal pressure. Just as we measure the mean arterial pressure when you're dealing with a patient with sepsis, or just as we measure the plateau and peak pressures when you're ventilating a patient, if you want to diagnose ACS, which is not a rare disease, it's present in almost 1/3 of your patients in the ICU, you should have to measure it regularly. So what about the physical examination? Well, just palpating the abdomen or measuring the abdomen girth is not a sensitive marker. The sensitivity is less than 50%. Okay, so you cannot diagnose raised IAP or abdominal compartment syndrome by measuring the abdomen girth or by palpating the abdomen. You either have to measure it, and the various methods of measuring it has been described as direct by the Cron's method, where you can measure it by directly inserting a catheter into the peritoneal cavity, which is obviously not recommended because you have to do it multiple times and it's associated with more infections and trauma. And otherwise, you can do it as intravesical through the Foley's catheter, which can be either intermittent or continuous, or through the intragastric to your nasogastric tube, or if you have a femoral line in the CVP, you can also transduce that because the changes in the abdomen pressure is reflected by the changes in the femoral CVP. Now, it is recommended that, or it is suggested that instead of having a intermittent reading of abdominal compartment syndrome, it is better to have a continuous abdominal compartment syndrome because patients do have fluctuations of intra-abdominal pressure. And if we are not having a continuous monitoring, we may tend to miss the peaks of raised IAP. Now, the reference, I'm not going to the exact details of it, but the standard of reference is measurement via the bladder. We instill a 20 to 25 ml of saline so that a continuous column of fluid is maintained, and that transmits the pressure to the transducer. We don't measure the pressure immediately after instilling saline. We measure it after almost 1 minute so that there's no detrusor contraction. We measure it in millimeter of mercury, and we measure it at the end of expiration in the supine position after excluding any muscle contractions. We zero the transducer level to the mid-axillary line or the iliac crest in the mid-axillary line, and that's where we do the measurements. Now, if you're doing a patient CT, example for a polytrauma patient, or for any purpose, if you're doing a patient CT, you can see that there is one thing that's mentioned is that if you have a anteroposterior diameter to transverse diameter ratio of more than 0.8, okay, then that is suggestive of abdominal compartment syndrome. And there is something else that is also called your peritoneal to abdominal height, PAR, peritoneal to abdominal height ratio. You can see that the peritoneum is somewhere around just above the IVC. So if you have a peritoneal to abdominal height that is more than 0.52, which again tells you that the abdominal compartment is stretching upwards, which will again is suggestive of abdominal compartment syndrome. Now, abdominal compartment syndrome is not just confined to a single system. Okay, it has effects that affects almost all the systems. We'll come to that in detail. First thing, or most common thing that is associated is you have when the pressure in the abdomen increases, you have the diaphragm moving cephalod, and that causes an increase in the intrathoracic pressure and decrease in the intrathoracic volume. So you can have basal atelectasis and reduction in the lung compliance. The FRC is reduced significantly, and this causes a worsening of your ventilator perfusion mismatch. It causes a reduced gas exchange, so your patient will have hypercapnia, hypoventilation, and hypoxia. So this usually results in problems with difficulty in weaning. And as I told you, when you have an increased capillary permeability, you can also have an enhanced translocation of bacteria. So studies have shown that patients who have increased intra-abdominal hypertension, you are at more risk for developing VAP. You are more at risk for developing VAP, and that too Klebsiella VAP. Okay. So it is probably because of either microaspiration or because of enhanced translocation from the gut. Now, when the abdomen moves up, I told you that the intrathoracic pressure increases and your central venous pressure also increases. Now, rise in the central venous pressure impedes your venous return from the brain, and that causes venous stasis in the brain, resulting in raised ICP. Now, this paper has also been published, but it has been shown that in almost 50 patients in laparoscopy, during laparoscopy, creation of a pneumoperitoneum caused when the ICP in the abdominal pressure rised, they had an increase in the secretion of vasopressin, resulting in oliguria. Okay, so probably that is one reason why you have oliguria in patients with raised intra-abdominal pressure. Again, the same thing, the diaphragm moves up, the intrathoracic pressure moves up, your CVP goes up, and you have compression on the abdominal vessels, so your left ventricle afterload increases. The elevated intrathoracic pressure increases the afterload of the right ventricle. So basically, both your right ventricle and your left ventricle fails. So clinically, your patient presents with low cardiac output, high CVP, and high peripheral vascular resistance. You have a reduction in your renal function. This is because you have a reduction in your renal artery blood flow, and you have an obstruction in the renal vein also. This affects your renal filtration gradient. How do you calculate renal filtration gradient? It's calculated by your glomerular filtration pressure minus your proximal tubular pressure. Now, glomerular filtration pressure is your MAP minus IAP. And when your proximal tubular pressure equals IAP, you have filtration gradient as MAP minus IAP, which is MAP minus 2 into IAP. So if you have a doubling of IAP, that results in a fourfold increase in the gradient, which significantly affects your net urine output. And you tend to develop an oliguria when you have an IAP of 15, and anuria develops when your IAP touches 30 millimeter of mercury. Similarly to other systems, your gastrointestinal system is also extremely affected. It causes a reduction in mesenteric flow, even when the pressure is just 10 millimeter of mercury. And IAP of 40 millimeters causes a reduction in celiac artery blood flow, while the SMA gets occluded by, not occluded, the flow in SMA gets reduced when your IAP increases to almost 40 millimeter of mercury. Now, this causes intestinal hypoperfusion. Intestinal hypoperfusion results in bowel ischemia, lactic acidosis, intestinal edema, and the vicious cycle goes on. It will also result in an increase in your abdominal wall blood flow, so resulting in the muscle edema there, and that also splints the body, so that it causes again an increase in your intra-abdominal pressure. There is associated decrease in your hepatic, arterial, and portal venous flow, so that there is a reduction in the lactate clearance and altered mitochondrial function. This is just a summary of the multi-system affection of the abdominal compartment syndrome, where in CNS you have a raised ICP and your cerebral perfusion pressure goes down. In lungs, you have all the pressures going up. Your peak inspiratory pressure goes up, your plateau pressure goes up, you have hypoventilation, so dead space ventilation goes up, and you have the lung compliance coming down, which results in the basal atelectasis. It results in the reduction in the blood flow in the bases. And so you have basically hypercapnia and hypoxia. Cardiovascular system is affected because your cardiac output comes down, your venous return comes down, and you are eventually dealing with a patient with hypovolemia, although your CVP is high and your SVR is high. Similarly, you have decreased blood flow across the liver and the kidney and the abdomen. Now, these patients are extremely prone for collapse post-intubation because all the pressures in the abdomen is going to be high. So the moment you start them to positive pressure ventilation, you're going to further accentuate the hypovolemia. And these patients are at increased risk for post-intubation cardiac arrest and death. So how do you diagnose these patients? Diagnosis is easy, or diagnosis should be easy or should be thought of by identifying the patients who are at risk for abdominal compartment syndrome. And we should be recognizing the clinical signs of abdominal compartment syndrome. And along with that, we should be monitoring it continuously or intermittently, especially in patients who have risk factors for abdominal compartment syndrome. I already told you the risk factors for abdominal compartment syndrome, which is either because of the reduced abdominal wall compliance or because of intraluminal contents, abdominal wall collections, or because of leaky capillaries. So the best way is always to prevent it. It is extremely important not to do overzealous fluid resuscitation in patients with shock or DKA, because these fluids will eventually leak out and cause abdominal compartment syndrome. But at the same time, if you have a raised intra-abdominal pressure, then the markers that you have to assess fluid responsiveness also becomes falsely negative. For example, if you have a raised intra-abdominal pressure, then you cannot do your PLR, etc., because PLR will be falsely negative in this group of patients. How do you manage it? Based upon what caused the ACS, management is also going to depend upon the management according to that. So you're trying to optimize your abdominal wall compliance. You are trying to evacuate the intra-abdominal contents. You are trying to evacuate abdominal fluid collections, if any. And you have to do a rationalized fluid resuscitation. And if at all there's any specific treatment, we'll see to that. You can increase the abdominal wall compliance by optimizing the pain. If the patient requires sedation, mild amount of sedation. If the patient is intubated, then the patient can maybe given a trial of neuromuscular blockade. Body positioning also affects the intra-abdominal pressure, and you have to see whether your body position is increasing the intra-abdominal pressure. Typically, although you have a raised ICP, it is recommended that you ventilate your patient. You keep the head of the bed of at least at 20 to 30 degrees. But again, mind you, even that increases your intra-abdominal pressure. So at times you may have to keep a patient flat or even in the reverse Trendelenburg position. In patients who have in patients who are still having intra-abdominal pressure, you can simultaneously look for the feasibility of evacuation of the intraluminal contents. You can do that by having a gastric tube placement. You can do an NG aspirate and NG suctioning. The abdomen is low. You think that the abdomen have obstruction down, you can try a fattest tube and put or an enema. Still not improving, you can try medical management first with either metoclopramide or even neostickmin with atropine as a backup. And you can also try endoscopic decompression. If you have fluid collections in the abdomen, you can try to drain it, either by, especially in case of pancreatitis or massive ascites, you can try to drain it by needle paracentesis or CT-guided aspiration of hematoma and abscess. And mind you, that it is always better to have a stepwise guarded approach in the management of intra-abdominal pressure. So, intra-abdominal hypertension. So if you have a raised ICP, then you have to start thinking of monitoring these patients more frequently. You should monitor it every 4 hours. It's not 44 hours, it's 4 hours continuously. And you titrate to see whether the IAP is maintained or increased. Now, all the 5 things that I mentioned, whether it is evacuating of the intraluminal contents, evacuation of the intra-abdominal contents, improvement of the abdominal compliance, fluid resuscitation, and optimized regional perfusion, all will go simultaneously, but in a stepwise manner. And you can see that the evidence for a prokinetic agent, adequate analgesia, and fluid resuscitation has been variable. So the best evidence is for ensuring pain relief, adequate analgesia and sedation. And you can also try a nasogastric tube or a rectal tube and do an ultrasfocus of the abdomen to see for ascites or localized fluid collections. And mind you, whenever you have a patient at risk for intra-abdominal pressure, it's always better to not to do an overzealous correction of fluids, because once you do that, once you have a raised ICP, we don't have enough data to say that giving more diuretics or giving an albumin with diuretic or even removing the fluids by CRRT or renal hemofiltration helps in improving the mortality or benefit once the IH sets in. Now, you can go in a stepwise manner where you can administer enemas, you can try percutaneous drainage, or you can try fluid removal once the patient is stable. But again, this is a there's no recommendation given for that. You may try it, but there has no evidence for this recommendation. And still it is not there, you can consider colonoscopy decompression, or you can call in for surgical colleagues to do a surgical evacuation of the intra-abdominal pressure. Now, decompressive laparotomy has been recommended for a fully manifested ACS, and this is the last resort that we use, where we just keep open up the abdomen and keep the abdomen open till the abdomen edema decreases. And it's extremely important to time this, because delay in the decompression can result in increased intestinal ischemia, and you can lose a large amount of bowel segment viability. So the consensus statements from the Abdominal Compartment Society recommends to do decompressive laparotomy in patients with overt ACS. Okay, and they gave a grade 1D recommendation for a decompressive laparotomy. But the problem is that once you do a decompression laparotomy, you can end up in ischemia reperfusion injury to your visceral organs. You have to deal with infections of the open abdominal wound, and the patients can lose a significant amount of fluids when your abdomen is kept open. So you have to try to close it as fast as possible once the cause of ACS has been addressed. And so the same thing has been given as a 1D recommendation by the WSA SACS group. And they also suggested that in patients with open abdominal wounds, utilizing a negative pressure wound therapy should be used versus not being used. So a negative suction therapy to reduce the intra-abdominal pressure is also recommended by the patients with abdominal compartment syndrome. So whether you have come to my second last slide, whether you have intra-abdominal hypertension or abdominal compartment syndrome, it's always better to have a algorithmic approach to these patients. Now, if you have a raised intra-abdominal hypertension, you should try to reduce it as early as possible. You should try to reduce your fluid resuscitations and optimize organ perfusion. But if your abdominal pressure is still high, the patient has ACS, and you have to identify and treat it as fast as possible. Now, if your abdominal pressure is normal, then probably just have to monitor it frequently every 4 hours. And if it is remaining as low, then the IH has resolved. Now, if you have an ACS, whether it's primary or secondary, you have to see for any organ dysfunction is there or not. And once you have organ dysfunction, you have to optimize all the medical options that you have. But if it's still persisting, then probably you'll have to go ahead with a surgical decompression. So I would like to say that this is extremely common. Almost 30 to 40% of patients in the ICU from the day of admission itself, both medical and surgical patients have intra-abdominal hypertension. Once it develops, once it sets in, it affects almost all the symptoms, all the systems in the body, and causing deleterious effects. It is associated with an increased mortality of almost 30% increased mortality. And you have to measure it. If you don't measure it, you're going to miss it. It is always better to prevent it, but later stages, you may require abdominal decompression. Yeah, thank you.
Elsa?
Yeah. Thank you, Jacob. For highlighting the various aspects of a very, very important topic that we deal with in our day-to-day practice in intensive care. as Dr. Jacob has said, I think we all need to have a very high degree of suspicion, and we need to constantly keep a watch, especially in a specific subset of patients with unexplained organ dysfunction or unexplained kidney injury. And this is a condition which, until unless you try to sort out or try to seek or try to it interferes with a lot of things that we do in intensive care. For example, the way we ventilate, your hemodynamic assessment is going to be compromised. The way we are going to feed our patients is going to be compromised. And many times, patients with abdominal compartment syndrome, despite not having abdomen as a primary source, you'll find it very difficult to feed them, and maybe temporarily you'll have to probably move to parental nutrition till you sort out the compartment issues. So be very, very judicious about the fluids, because you will go into a vicious cycle where there is ongoing capillary leak. You will be tempted to give fluids. I don't think there is any responsive parameter which can be used, exclusively in abdominal compartment syndrome. So just be very, very careful when you have these patients with respect to fluid resuscitation. That's yours. Thank you.
Thank you, Ghanshyam. I think it's now of care that all patients who receive fluid resuscitation need to have their measurement of IAP done. It's not necessarily that it is pancreatitis or burns or one of those classic conditions associated with previously described as the classical situations where AC abdominal compartment syndrome happens. As Jacob pointed out, it is not the actual quantum of intra-abdominal pressure that makes a differentiation. It is the effect of such a raised pressure on hemodynamics, renal perfusion, mechanical ventilation that makes a difference. Two important points to be remembered is that the ICP is significantly influenced by intra-abdominal pressure. So in a patient who has a traumatic brain injury as well as intra-abdominal trauma, it is all the more important for us to measure the intra-abdominal pressure. Similarly, just like you have cerebral perfusion pressure and coronary perfusion pressure, you have abdominal perfusion pressure. So if you are dealing with somebody who has a dysfunctional gut with rising lactate, if you want to know whether the gut is ischemic or is getting adequately perfused, the abdominal perfusion pressure is an important guide in that direction. So the mean arterial pressure minus the IAP or intra-abdominal pressure is what abdominal perfusion is about. Is. So a pressure of less than 60 is associated with some degree of gut ischemia, and less than 50 is definitely associated with significant dysfunctional gut and mesenteric ischemia. So this is the importance of intra-abdominal pressure. So I think it now is added to the hemodynamic monitoring as well. When it comes to hemodynamic assessment of somebody with intra-abdominal pressure, there are several formulae and calculations which have been derived, but simplest thing is your actual mean arterial pressure which you are targeting is mean arterial pressure minus 1/3 the intra-abdominal pressure is something that is accepted as the actual mean arterial pressure. It has an important bearing on your sonographic assessment of fluid responsiveness because the IVC is compressed in patients who have intra-abdominal hypertension. So if you are actually measuring your IVC delta, then a patient with intra-abdominal pressure is not the patient on whom you will rely entirely or solely on IVC assessment. Similarly, for the assessment of the fluid overload, currently standard of care is VEXAS, and VEXAS begins with assessment of the IVC, and the algorithm starts when the IVC is more than 2 centimeters or 20 millimeters in diameter. But that fact also may have to be revised, and we need to understand the effect of intra-abdominal pressure on the IVC diameter, because fluid overload is one of the conditions which actually causes a which increases the IAP. So this is a vicious cycle. If you do not do the full vexus because the IVC is collapsed, you may be missing some patients who have fluid overload and intra-abdominal hypertension. So these are some points I thought I will add. Next week we will meet about a emerging paradigm in intensive care, that is post-intensive care syndrome. We will talk about it next week. Please join us again at 8:15 next Tuesday. If you have any questions or queries or doubts on this topic, please do post them on the group from which you got this link from, and the speaker and the moderator will try to answer this.
Yeah. Srinivas, just one. Jacob. Hello.
Yeah. Yeah.
Jacob, you mentioned high PEEP as one of the risk factors for abdominal compartment syndrome, isn't it?
Yeah. So this was found, this PEEP more than 7 was found as an independent risk factor for intra-abdominal hypertension in that IROI study. Probably it is because if you are, the diaphragm is moving to, you're pushing the diaphragm down, and that causes an intra-abdominal compartment.
Okay. I had a similar thought, then I suddenly realized, is there a cutoff level at which, or because we will be ventilating a large number of our ARDS patients with,
To start with, yeah.
Okay.
But I didn't find any cutoff for that, sir.
Okay. Okay, Jeff. Thank you.
Okay, we'll meet again next
Thank you.
week. Have a good day. Bye-bye.